Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. Welcome back to Open Mics with Dr. Stites, not Coomer. Medicine is a team sport. Oh man, did I just say that and that? I don't know. And today we're highlighting a couple of key players on the team. Clinical nurse coordinators are just a phone call or a MyChart message away, ready to answer patient questions and concerns. They are a lifeline for patients. They're a resource for all things our patients need, and trust me, we would be lost if they weren't there. At the desk with me is Joyce Funk, the clinical nurse coordinator in the Cystic Fibrosis Clinic and our lung transplant follow-up clinic. We've been working together a very long time. We've promised not to embarrass each other. I'm not going to tell you how many years we've worked together. 22. Dr. Sean Coomer is also here alongside Shauna Schaefer, a clinical nurse coordinator for the hepatobiliary transplants. That's liver, pancreas, bile duct transplant. I should have said hepatopancreatobiliary. I don't know how you say all those. It's kind of one
HPB.
long. Yeah, it's a big long word. Shauna, Dr. Coomer, thank you guys for being here. Obviously, Dr. Coomer hosts when I'm not here. He and I are pretty good friends. You might notice today, though, we're going to give each other a little bit of a hard time because that's what we do. Now, Shauna, how long have you been working with Dr. Coomer?
I've been working with him about 7 years.
Good. Are those the best or hardest years of your life? Just tell the truth. That's the thing.
They are both.
Awesome. Huh. Okay, so how would you describe your relationship?
I feel like it's a good professional relationship. I think over the years, he's really grown to trust me, and I support him in clinic by supporting his patients and being there for them. So that helps him do his job. And
have you taught him a little bit about how to be a better doctor? Is that part of the deal?
No, I feel like he does a good job on his own. He's been very informative and educational for me since I've been his nurse, and he just he gives his patients the empathy and time I think they need, and so. All
right, well that is a kind thing. Now, Sean, describe the relationship. How has it changed you, and how has the way you guys work together changed over the years?
Yeah, over those 7 years, there have been a lot of changes to my role here in the health system. So
yeah, maybe.
Shauna has been there.
Who knows what's coming next?
Exactly. Shauna has really gone through that with me. And she is, I mean, I can tell you every time the patients come in, they go, "Oh, you're Shauna, thank you so much." It's never, "Oh, you're Dr. Coomer, thank you so much." It's Shauna. I always turn to Shauna and ask in the clinic, "Well, let me check with the boss." And she's so fantastic with the patients. She is empathetic, caring. I mean, she just, makes that clinic what it is.
You know, that sounds hauntingly familiar because if I walk into a room and you're not coming in with me, the first thing I hear is, "Where's Joyce?" You need your brain. So would you say we work together well?
Yeah, I think we work really well together.
Yeah.
I think time has obviously created some of that ability to work together, but I do think it was very fortuitous even when I started. We have very similar clinical approaches to patient care, which I think has really made it work really well.
And tell us what that approach is in your mind.
In nursing school, I always hated him talking about the art and science. I'm like, I like the science. But it's became very clear over time that art of caring for the patient, and especially caring for folks with chronic disease, is so incredibly important. And so I think we really balance out addressing the imminent medical concerns with taking care of the emotional aspect of care. So
yeah, because without hope, what is care really? And so, okay, so now Shauna, man, I am going to screw that up today. I just realized how close it is. SNS, you let a camera tag along with you recently during one of your clinic days, and we can see Dr. Coomer is focused on the patient. And Shauna, you're listening, but your eyes are also on the computer. Kind of tell us what you're listening for. What are you doing with the EMR? What's going on there?
Well, I like to give my patients a good documentation, a reference to take home with them, and so I'm providing written education material, surgery information, everything that is discussed in that visit, because a lot of times patients only take home a small portion of that because they're very overwhelmed or they're just too information overload. And so I like to provide that reference for them when they leave the clinic.
So what do you do during a clinic day? And then tell us kind of what you do when it's not a clinic day.
So when it's not a clinic day, I triage patient calls and triage what their concerns, whether it's pre-surgery, post-surgery. I provide the education that they're needing. I also have an ongoing patient list for follow-up as far as images that are due, endoscopies that are due, and then pathology reports that need resulted out and information delivered to those patients.
And some of those common questions and issues patients are calling about, what would you say those are?
Mostly post-operative symptoms. Are these symptoms normal? Is the drainage that's happening in my incision, is that normal? Because everything just feels out of sort post-operatively, and so they just need some of that confirmation that this is what's supposed to happen. And I feel like that's the most common question.
So Joyce, oh gosh, I said Joyce. I call her Joyce a lot. I don't know where it came from. It just pops out. So describe what you feel like our clinic day does, and I'm going to describe it too, because I think.
What our clinic day does.
Yeah, what is that like?
Well, there's a lot of directing Dr. Stites to what room he needs to go to.
I really don't know. I can't ever figure out the screen or how to make the screen move. I don't know what I do.
With working in the cystic fibrosis clinic, we work with a team when we go to clinic. So it's not just he and I, there's pharmacy, social work, respiratory therapy, dietitians. So he and I go into rooms together. So I think a lot of kind of what I saw with you guys, I'm certainly at the computer doing a lot of exactly what Shauna said. At the same time, I'm listening to come up with the to-do list of what's going to be happening outside of clinic. Yeah.
I think it works great that we both go in the room at the same time, and I bring an iPad in so I can remember what I'm supposed to ask. I look at my last few clinic notes. That's how I remember anything. And it works great because the patients see us working together as a team, and you're going to cover things that I might forget, and I'm going to go through the medical stuff, and together I think we really, we try and do a great job of taking care of patients every day. That's always the goal. Outside of clinic, there's a lot of work because I see you here like all hours of the day.
Yeah,
At night.
I love clinic because it's when we get to actually physically see the patients, talk to the patients, address immediate concerns. But, at the same time, it's also when we develop our list, our to-do list, right? It's the to-do list for, the next 24 hours and from there, from one clinic to the next clinic. But yeah, we're also doing that coordination of care with outside providers.
Who's that old guy up there?
What?
Who's the old guy on that screen? I don't know that. That's not, oh man. I don't know what happened. Go ahead. I'm sorry.
You're totally
Holy cow.
So yeah, lots of coordination care, right, with outside providers, whether it's other institutions, physicians, third-party payers, home infusion companies, etc. There's just a lot going on.
Yeah. Well, and I think there's so much work we do during the day, and we still call patients kind of the old-fashioned way. I like to talk to people directly, and I think it means a lot to our folks when we call them, and we often will do that together, especially when we've got big-ticket items that we're talking to patients, and there's a lot of that in a transplant CF patient population. So I think it's really, to me, it's all about the team. So, and I'm going to bet you would say something similar to that.
Absolutely. Well, when you asked Joyce what's the day, in between clinics, I thought she was going to say a good day. Not with you. But no, I mean, you're absolutely right. I mean, the coordination of care, the things that we work together on, the time she's chasing me by text or email or whatever it is to keep my life straight and ultimately our patients straight is incredible. She is the key to making excellent patient care happen.
So I think you just described why it's so important to have a registered nurse, or an RN, or an ARNP available and able to help us do what we would call case management. I think this is kind of the case management spectrum because there's so much work you have to do for a sick patient to navigate the strangeness and the hardness of the American healthcare system, because it's a hard navigation. So guys, tell us what you feel like your job is. Is it rewarding? Is it challenging? Is it painful because of the people you work with?
You'd like me to go first. I'll go first, Shauna. Yes. No, it's fair. I mean, obviously it's rewarding. We wouldn't be here if it wasn't.
We have that on tape.
That's not to say it's not challenging, right? And I think the challenges are not just in dealing with chronic disease, but they're in access to resources, which is obviously getting more challenging all the time. There's challenges in, and I'm not speaking for Shauna, but Dr. Stites has worn many hats for many years. When the physician that you work with is not just doing clinical work, there are challenges in trying to figure out how to do that patient care in a timely manner around their schedules as well. So, yeah.
It can be hard. So, Shauna, thoughts?
I agree a lot with what she said. It is rewarding, but there is a lot of things, moving parts when taking care of patients, from just the immediate clinic side all the way to, the final end of your care or treatment for that patient. The insurance companies, the home health, everything of that nature. And then, yes, trying to track down your physician in the process when they do wear many hats, as ours do. So,
So you've both been trained additionally, I think you have an RN degree, but then you're doing this case management. What other things have you had to work and learn to do that?
Mainly just the changes in insurance. I feel like it's always changing, and the prior authorizations, and then a lot of the insurances farm out their approval, their authorizations to other third-party companies. So you have to go through multiple individuals, multiple facets in order to get the end result is getting your patient's treatment approved or their scan approved. So I think that's been the main, issue.
And you would say the same thing, I think.
100%. Yeah.
And what percentage of your job do you spend on that?
More than I would like to. I'm going to be completely honest. And I think it's really transitioned over the years. When I first started out, I felt like I was much more clinical heavy. And now I think when I am not in clinic, the majority of my time is trying to get things approved, or trying to get patients access to care.
What a fight. So, Shauna, talk to us a little bit, your career path. How'd you end up working with him? Godspeed to you.
Well, originally I was a registered dietitian in the hospital, and then I went back to nursing school. And then I really was interested in critical care, so I started at KU in the medical ICU.
What a great unit, by the way. Well done.
I know. I saw you a lot.
Hopefully I was nice.
And then I transitioned to transplant and hepatobiliary surgery after at ICU. And so I love the science and application of critical care, and that served me well in transplant and hepatobiliary surgery. So.
Yeah, it's a big one. Now, Joyce, you've had your career path too. It's different than that, but I mean, you've been on the outpatient side and hospice and all sorts of things.
Yeah. So I'm what I consider a KU lifer. I did my undergrad and grad school at KU. Started working here out of school in the medical oncology unit. Loved that. Did a brief stint with hospice, then came back and was an inpatient case manager for 7 years, which is where I met Dr. Stites, working with the cystic fibrosis patients. And then in 2004, transitioned to the outpatient pulmonary area.
Thinking you were going to actually work with Dr. Tim Williamson, I think, actually.
I took the job to work with a different physician. Day one, I was given the great news that I'd be working with Dr. Stites.
Yeah, I think the nurses were, but hey, Joyce, you can work with just one doctor. I'll take two doctors.
They didn't tell me that working with one was more than working with two.
Yeah. So guys, now more than ever, nurses are encouraged to speak up. And the old school was doctors give the orders, nurses follow the orders. Okay, I'm just going to tell you, I don't live in that world. I don't know what you live in.
No,
I do not.
No, I do not.
And actually, thank God we don't live in that world, because what a terrible place to be, because people wouldn't feel empowered to tell you when you were screwing up. So Joyce and Shauna, do you feel like nursing in general has changed since the start of your careers?
I feel like, yes, it has. It's not the same traditional adage, I feel like, that nursing used to be. And nursing is really based off of evidence-based medicine, and then a magnet program like we have here. And I think that all just facilitates, the change in nursing over time. And it really has been helpful. I think at KU, it helps nurses with their autonomy and then the collaborative care that they provide with physicians and the whole team. So,
yeah, I feel like I've been a nurse forever, so it has changed in so many ways.
You're only 35.
I know. It's amazing what I've done in that amount of years. But it's certainly changed. I mean, obviously, back in the 90s, everything was on paper.
Yeah.
We have transitioned in so many ways. But I think one of the things that KU has always done, and I think always done really well, is the nursing culture has always been one where they have, and I think, being a teaching hospital, maybe that has had a little to do with that as well over time. But there has been a lot of emphasis on nursing autonomy, nursing empowerment, collaborating with the physicians and being able to develop a good team concept.
Well, I'm just going to say it out loud. I've been at KU for a really long time, and I would say probably the longest at this table. And the thing I've most noticed, the greatest single change here, is the nursing staff. And I can't tell you how important I think the magnet journey is, inpatient, now outpatient. I mean, it's made a huge difference to our ability to deliver good care. And I think nursing empowerment's made a huge difference to our ability to provide high quality care. You and I kind of flit in and out of places in the rooms. The nursing team is with the patients all the time, inpatient or outpatient. And I'm impressed that without our nurses, the glue that really keeps patient care together wouldn't be present, and especially those eyes. If I round on an inpatient service, I may see 30 patients in a day. The nurse is going to have, let's say on a regular ward, 4 or 5 patients, and just think how much more quality time you get to spend, how much better you are at understanding what those patients' needs are. And I think that teamwork makes a phenomenal difference. And so the way we do care now is so different than when I first came here, and it is so much better. Okay, so forgive us for putting you on the spot. What can we do better as physicians? And just to say, there's a part of this I missed a minute ago about, we do a lot of different jobs, and Kuma here doesn't wear scrubs. He always wears a suit now. And I suspect part of what you have to do is keep us focused on the job. But beyond that, talk to us a little bit about what we can do better and what changes you would like to see from us.
you go ahead.
Okay, I'm happy to go.
Oh, here it comes.
Here we go.
What I can do.
Yeah, exactly.
No, I think it's all about collaboration, right, and communication, right? If I was to pick, and repetition. That was going to be my word that you didn't let me ask or answer earlier. Is, I think as long as we continue to work on those things, and every day is a different day. I mean, you may be pulled one direction, a little bit more one direction one day, a little bit more another the next, and so I think it's my job to try and emphasize when there is a clinical concern that needs immediate attention. And so I think our ability to relay that to each other is good. I mean, sometimes it's a work in progress. There are some days I think he really
each other. It's only going one way.
Some days I think he really understands my urgency, and other days I'm like, I'm going to have to rephrase that. So.
Shauna, do you ever ask the same question in different ways,
Repetition.
hoping to get a different result?
Yes.
Some might call that repetition.
Yes, and then I have my own triage of how I present the information.
So tell us about that triage, because I'm curious what yours
We
is
look
like.
at the urgency, and then does it go into an email? Then does it go wait till we see each other in clinic? Or does it go to a text? Or does it warrant a call?
So it escalates up. Huh? That's what I hear you saying.
It depends on the patient, the situation. That's kind of how
Yeah.
I
It's usually, sometimes there'll be a couple emails, and then usually the text will say, hey, dummy, did you look at the 2 emails that I sent? I need you to look at them now.
Well, yeah,
she phrased it much nicer than that, though.
When I hear, have you seen my emails? I haven't been on email today. Well, maybe you should look at the email and see what I put out there. then I'll get it in a text, and then I'll get it in a, and the texts have different flavors. There's hey, can you call me in a few minutes, or call me when you have a meeting, when you have a break, then please call. Then it's just call. And then I get a phone call. Fair?
That's fair.
Pretty accurate. Okay, all right, folks. Well, listen, this is great. I just want to say again how important these relationships are to patient care. Unless you're in the mix, you just don't know. And the ability to have a relationship where people can be honest with each other, holy cow, makes all the difference, because patient care is hard. And when you take care of transplant patients or transplant and CF patients or hepatobiliary, that's hard, right? These people are sick, and they take a lot of eyes to keep them well. All right, we're here to answer your questions. Send them by using the links on your screen, YouTube, Facebook, or email the Medical News Network. We're going to check in now with Doc Hawk. Okay, Hawkeye, summer's heating up. Prime time for vector-borne illnesses carried by bugs like ticks and mosquitoes. A few things to cover, but first, before we talk about ticks, nursing to you. You depend on nurses a lot in the ID clinic and when you're around.
Yeah, I think we've been doing this too long, because I was thinking that exact same thing, especially with our outpatients who have bad infections that require IV antibiotics. Our nursing for our whole ID division is so important and so vital. And I get the same thing when I walk into rooms as well. Those patients appreciate those nurses much more than myself, and I think that's a good thing, because they help coordinate and keep those patients safe as we are giving them antibiotics and monitoring their infections moving along. So it is vitally important, I would agree. Shout out to the ID nurses and all those outpatient nurses coordinating care out there, and shout out to my nurse Jessica for helping as well. So yeah.
All right, so we're going to talk about ticks, and I don't mean troublemaker in chief, which is what I call myself, the tick. So remind us where we should be looking for ticks, and I mean, don't be too graphic here, you know what I'm saying.
Yeah, no, exactly. I think everybody is getting outside now. It is becoming nicer weather. We've just passed the Memorial Day holiday, so people are going to be out doing things. Last week we talked about what to do to help prevent ticks. That's treating your clothes, spraying bug spray on yourself, knowing and understanding where you're going, and then doing tick checks. And where do we check for ticks? So once you get in and you remove all your clothes and you're getting ready to shower, because you want to do that 1 to 2 hours after getting inside, it is vitally important to check for ticks. We have a very good infographic here from the CDC just showing those areas where you want to be checking, especially around the hairlines, in the waistband, in those crevices, the armpits, the groin, things like that. Looking for ticks and removing them as quick as possible. Remember, there are a lot of diseases that can be spread by ticks, most notably around here ehrlichiosis and Rocky Mountain spotted fever, which are bacterial diseases. We don't really have a lot of Lyme here, even though we have the ticks that carry them. We have those other bacterial diseases, and then of course Bourbon virus, Heartland virus, which are less common as well. But you really want to make sure you are preventing tick bites, and then if you do happen to have a tick which gets on you when you are out, come in soon after getting in from the outside, take off your clothes, take that shower, but do that tick check as well to help prevent any problems or issues of just even a tick getting embedded, not even spreading a disease.
So did you just say Bourbon virus?
Bourbon virus, yeah.
Seriously?
Yeah.
It's not like, Jim Beam bourbon virus.
It's not like fun bourbon, no. It's actually
just
named
checking on you.
Because the patient that it was discovered in was actually from Bourbon County, Kansas. So
okay, well there
we
you
do
go.
have some native viruses around here. I'm sure there are a lot more that we just would like to look for and investigate. Certainly we need funding for that. That is vitally important. Continued science and medical funding is vitally important overall.
Okay, now you see illnesses from mosquito bites every year, like West Nile virus.
Yeah.
Wow, couldn't say it. Is protection as simple as bug spray?
It certainly is. It's the same kind of protection we just talked about overall for prevention. Wearing those long clothes. We know these mosquitoes can bite in the daytime or the evening and the nighttime. But yeah, wearing those long clothes, wearing that bug spray can help prevent those mosquito-borne illnesses. Now, luckily, around here, we are very fortunate. Is the main one really is West Nile virus. We don't have some of those other bad ones as of yet, but we always have to keep monitoring for those things like dengue virus like chikungunya. Certainly, we used to have yellow fever and malaria in the United States. We've kind of been able to eliminate those things, but I think as things change, climate change, increasing population, also people becoming more interactive and interacting with the world around them, we just have to be ready for those things and monitor. But prevention is always the best medicine. So.
All right, speaking about prevention,
Yeah.
new recommendations from the CDC, or at least in the federal government in different branches,
Yeah.
about what we should be doing with the COVID vaccine.
Yeah, it seems like there's been a couple of announcements the last couple weeks. Obviously, yesterday there was a big announcement by RFK Jr., the Health and Human Services Secretary, who said that the vaccine for COVID, so the COVID updated vaccine, will no longer be recommended for healthy children and pregnant women. We know there have been some comments on that by the medical groups for obstetrics and gynecology, as well as pediatrics, who aren't really sure that this is the safest thing. I think it's always okay to ask those questions. And remember, times are different now than they were in 2020, so people have been infected and reinfected. People have been vaccinated and revaccinated. We do know and understand that you do get that long-term immunity, specifically antibodies, but also more so to help prevent severe disease from those T cells. That T cell immunity is vitally important. But I know this is causing a lot of different thoughts among the medical community. We just want to do what's best to keep everybody safe. We know that in general, healthy children, yes, are at less risk of hospitalization and severe disease. Certainly that is vitally important. But we also know that giving the vaccine can help reduce the chance of long COVID. Now, what does that look like in 2025 after infection, reinfection, repeated vaccination as well as compared to 2020? I don't think we know that yet, but we are looking at those final recommendations, which will be coming down the pike as this first announcement was made yesterday about lack of recommendation of the vaccine, the updated vaccine, for healthy children and pregnant women as well. So we will see what happens, and again, we'll continue to follow the commentary, especially by those experts in those fields that deal with those patient populations as well.
So it's interesting that they've shifted. Now, you and I have always taken this very evidence-based, kind of very calm approach to this. And the pregnancy question concerns me a little bit because we knew that COVID had bad outcomes in pregnancy. Is that still true, or has that evidence changed?
You know, I think that's hard to say just because of what we have said. You know, it's different in 2020 when you have a newly pregnant mom or about to give birth, as opposed to 2025 when most people have probably had one or two infections at least and have been vaccinated. The main concern, I think, from the obstetrics and gynecology group and physicians is that giving that vaccine is going to give that boost to the antibodies, which will then be transferred from pregnant mom to baby to give that baby protection for 6 months. So I think that's the big concern there. Overall, unfortunately, we don't know what the final outcomes will be and what will happen. Luckily, right now, we have a low circulation of the virus in the community, low amounts of COVID diagnosed and in hospital, but we know that could change really in a couple weeks. So we just have to wait and see how it plays out. Hopefully those numbers and infections will stay low. But yeah, overall, I think it's going to be an interesting thing to see what happens here in the next few months, especially in the fall as we get into respiratory viral season, and when that vaccine will be available for administration as well.
All right, we know many of you have questions. Let's head to Studio B with Alexis.
We have a question. Sorry, what?
I said good morning, Alexis.
Oh, good morning. Good morning to you. Dr. Hawkinson, we've got a lot of questions coming in for people who just want clarity on these new recommendations. Nate wants to know, does the decision to not recommend COVID vaccines for children and pregnant women mean there's a greater risk for people over 65 who do have immune compromising conditions?
I think that's a very good question. We do know that getting vaccinated can help reduce your viral load and spread of the disease. So what if that person or that pregnant woman, that child or that pregnant woman is in a household where there are at-risk people? That is a very good question. That is not addressed. And again, this was just the first recommendation announcements. We'll wait for the final recommendations, although I don't think there's a reason to understand or know that that's going to change from what was announced yesterday. But I think that's a very good question, and that's a very good thing that we'll have to continue to monitor and answer. But we do know that those most at risk of severe outcomes, those with comorbidities, even if they're under 65, remember the recommendation was going to go to those 65 and older to get the vaccine, and then if you are otherwise high risk, if you are under 65, you can get the vaccine as well. So we need to understand that it will be recommended for those over 65. If you are younger than 65, if you have a high-risk comorbid condition, you can get it as well. But those that are over or have high-risk comorbid conditions should be getting the vaccine, so they should have and mount good protection against severe disease and hospitalization.
Stuart has a question about coordinators. Stu wants to know, are there different coordinators for different transplants?
Shauna?
Yes, in our transplant department, we have nurse coordinators for heart transplant, liver transplant, and kidney transplant, and pancreas. So we all treat patients, within our prospective organs.
And so for us, obviously, there's not a lung transplant program at KU, so there are a couple of physicians in the pulmonary division, actually 3, that follow most of our post-lung transplant patients. And so that there's now 3 coordinators that work with those. So yeah, so that we have some local care for our folks.
And it's interesting because I would say, we send out 30 or 40 patients a year to go get transplanted somewhere else. A lot of them going to St. Louis. And so hopefully someday they'll stay here in Kansas City. Maybe Coomer in his transplant role will help us get that done. I don't know. As far as he's below the diaphragm.
Yeah, I'm not sure what to do up there.
Yeah. So they're remodeling our offices right now. And not only are we sharing this program, we're sharing our office too.
Yeah.
That's going to go on for a few months.
I mean, yeah, a little bit longer. I mean, everybody has that college roommate back in the day that came barging in, and that's what we do to each other. Yeah, so that's what it is.
There's nothing sacred about your office. All right, this has been a great discussion. I am really grateful that Joyce and Shauna have both agreed to be here today. I can't tell you how important that relationship is that at least you and I have, and I know that you guys have, and all our best physician nurses teams have. And it's one based in honesty, transparency, intelligence, and just working together in a way that delivers the best care to patients, and our patients know it. And I think that's when you know you're doing it right. So, well, final thoughts before we go. Joyce, let's start with you. Yeah, you say anything you want. This is your golden moment, right?
This is my golden moment. No, I honestly, I just want to say thank you. It's been a great ride. 20 plus years. No, I mean, I do think that if you're really, really fortunate in your career, you find somebody to work with who has, similar outlook and goals and focus. And I've been lucky enough to find that. So thank you.
Absolutely true.
Well, I feel pretty much the same. The last 7 years have been great. I feel like our working relationship has been good, and his trust in patient care that I provide makes a difference, and it's that autonomy that he allows me so that we can give the best care we can.
Coomer.
I just want to thank all the ambulatory, inpatient, OR, procedural nurses out there. The majority of care to patients really happens with the nurses. And they provide such a stable situation for our patients that progresses their care to finality in a good way. And I can't say enough to thank Shauna, because she makes sure our patients are taken care of excellently. And what I mean by that is not only their health care, but their well-being, and make them feel good, make them feel informed, make them feel trusted and supported through that. So Shauna provides that, and I'm forever grateful.
And I know Coomer well enough to know that he means it, and as I know what an outstanding doctor he really is, and that's why he's the chief medical officer for this hospital. And I watching you guys work together is kind of like watching Joyce and I work together after a year. It's pretty awesome.
Yeah, I would have to echo that as well. I think the coordinators, the nurses, all help to keep what we want as well, and that is people out of the hospital and healthy, and so they're vitally important for doing that. In regard to vaccine recommendations, once they are final and they do come out, we will be here to answer the questions and try to clear it up as much as possible for everybody. We know it is getting into a confusing time, but we will be here to help clarify everything. And I will say that walking by your guys' office when they're together, it's kind of like walking by and watching an episode of Perfect Strangers, if you know what that was. So if anybody's not busy this weekend, go binge watch that, and then tell me which one you think Dr. Coomer is and which one Dr. Stites.
I thought it was a nerd show. I thought it was going to be one of those things.
Perfect Strangers? No, not a nerd show.
Well, yeah, that's how I am. Okay, so on this program, forever, we've talked about flying the plane. I'm going to let everybody in the public know something that's important. Sean and I don't fly the plane. These guys fly the plane. What we do is we try to help, think about how's a good way to build the plane, what's a good way to do this or do that. But at the end of the day, these guys really are the ones that are piloting that plane. And everybody out there in the public who gets care at the University of Kansas Health System, hopefully you share in the same sense of gratitude that I have and that Sean has for the pilots. Because these guys, the nursing staff here, are the ones who are really doing the work on the direct patient care side. And I love what you said about wellness. It is true on both of those things, because good, great care is also wellness. And I have been blessed to work with a person who I think is one of the best nurses in the world and a great friend. And that honest relationship where people can just sit and have a good conversation about what's right to do for these patients, it means everything to patient care. Because that means you're going to get the best therapy and the best treatments because you've had the best conversation between the nursing staff and the medical staff. Whether you're on the inpatient side in the medical ICU or you're on the outpatient side. And for 22 years, I've had the pleasure of working with a great pilot. Thanks again to all of our guests and to our audience. Remember what we always say, faith, hope, and science. And we'll keep building that airplane while we're flying it. We'll see you soon.
I'm Alexis Del Cid on the next All Things Heart.
I was born with a heart condition called tetralogy of Fallot.
That's when 4 different heart defects develop all at once. We'll show you the science making it possible for this sonographer and mom to live a full active life. Thursday at 8 a.m.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.